Hello, welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. I want to note that today's Grand Rounds presentation is a joint presentation with the Department of Global Health. This year for Psychiatry and Behavioral Sciences Grand Rounds, we've moved and started a new series in a webinar format, and we have 4 advisory panels and training leader to advise us on including individuals to present in 4 main areas. And I wanted to acknowledge funding for the series as well today through the Ripley Fund. The several staff members, including Samhar, who helps with coordinating the series. And last week we piloted out a new feedback and survey evaluation form. We've got that up in Catalyst this week. And we're going to start including that evaluation form in the Grand Rounds announcements, which should make it a lot easier to fill out the couple of questions afterwards to give feedback on the presentation. I'll pause for a moment and call on Dr. Jason Best here to give a few comments about today's presentation. And after that, Dr.
Well, yes, thank you.
Sorry, Jason. And after that, Dr. Pamela Collins will introduce today's speaker.
Thank you so much, Joe. As Joe mentioned, my name is Jason Bestie, and I'm an infectious disease physician in the Department of Global Health and in the Division of Allergy and Infectious Diseases here at the University of Washington. And on behalf of the Department of Global Health, I would like to welcome all of you to this joint Global Health Grand Rounds hosted by the Department of Psychiatry and Behavioral Sciences and the Department of Global Health. The Department of Global Health believes that mental health is central to the field of global health, and we are absolutely thrilled to have a phenomenal speaker talk with you today who has had just some amazing, inspiring work that she's going to share with us today. Today's Grand Rounds is particularly important because it's the first joint Global Health Grand Rounds for this academic year between the Departments of Psychiatry and Behavioral Sciences and Global Health. We look forward to continuing this collaboration in the future. And for those of you who may be interested in attending other global health related Grand Rounds with other clinical departments across the University of Washington, please visit the University of Washington's Department of Global Health webpage for more information. With that, I'll pass it over to you, Dr. Pamela Collins.
Thank you so much, Jason. Hi, everyone. I'm really delighted to introduce Dr. Victoria No. I've known Vicki for more than a decade, and it has been a pleasure to watch her work that is sensitive to the needs of individuals, communities, and contexts expand in reach and impact. Dr. No is an associate professor of community health and social sciences at the City University of New York Graduate School of Public Health and Health Policy. She's the director of the CUNY Center for Innovation in Mental Health and Director of Global Mental Health with the Community Center for Immigrant, Refugee, and Global Health. She's also an adjunct behavioral scientist at the RAND Corporation. She's a licensed clinical psychologist who brings expertise in developing, evaluating, and implementing evidence-based treatments such as cognitive behavioral therapy for depression, anxiety, and trauma in diverse communities in the United States and abroad. Her research pays particular attention to understanding and promoting implementation strategies that can increase access and quality of evidence-based mental health services for ethnic minorities and underserved populations around the world. Since 2000, she has worked to develop research and clinical training capacity and infrastructure in Vietnam, including development of the first graduate program in clinical psychology and development and evaluation of the multi-component collaborative care for depression program, which was the first program to integrate mental health services into the primary healthcare system in Vietnam. And after this, she developed Life DM, an integrated depression care and microfinance program, which she will tell us about today. She plays many other leadership roles in global mental health. She leads a USAID-funded learning collaborative for mental health and psychosocial services for trauma-exposed populations in low and middle-income countries. And she's a member of the Centers for Disease Control, Cancer Prevention, and Control Research Network, where she co-leads the mental health and psychosocial integration work group of the network. So she brings a lot of experience, wonderful leadership. And with that, I'm going to turn the floor over to Dr. Victoria No.
Hi, good morning or good afternoon for most of you. I'll share my screen. This out. Sorry, I'm trying to navigate here. Can you guys see it?
Not yet.
Oh, it won't let me.
Okay, she needs co-hosting.
Yeah, let's see here. Mike, do you have an idea about that?
She should have rights. Let me double check.
Okay, thank you.
It says, yeah, screen shares failed to start.
Well, while we're checking on that, I'll make a comment to the participants. Please type comments and questions into the chat box, which we can go through at the end of the presentation.
Are you able to see it yet?
Not yet.
Well, I guess I'll just start, just to thank you all for having me here today. I'm thrilled to be here. UW is one of the institutions that I've been wanting to be part of for so long. And, as an undergrad applying for grad school, postdoc, and then also later on. So I'm, really looking forward to learning more about all the different work that you guys are doing and explore potential areas of collaboration. I'm also just really grateful to Dr. Collins for her years of mentorship for me. She's actually one of the reasons why I'm able to do the work that I'm doing now in Vietnam, and so just want to thank you, Pamela, for that. And I don't know if we're able to share yet. Is it working? It says it won't let me share, but it looks almost like it's shared because it's got that blue box around the slides.
Dr. No, I will be working on this and talking with Mike, and after there's some update, I'll stop. I'll interrupt and let you know.
Okay.
Sorry about that.
Oh, no worries. But I guess I can, just tell you a little bit about myself. I'm Vietnamese American. I'm also a refugee from Vietnam. And so the work that I'm doing in Vietnam is really, personal for me. And it started actually in grad school, where I had this opportunity to go to Vietnam to just learn about mental health. And I was very fortunate to be able to spend a year just combing through the country through an NIH funded grant and visit pretty much anybody and everybody that was doing anything related to mental health for a year. And so that was, that really built the foundation to a lot of the work that I ended up doing. And from being in Vietnam and working in places where there just was not any kind of mental health services available, led me down this road of trying to figure out how to develop mental health services where there was no infrastructure, and then, which resulted in all the task shifting programs that I've been involved with. So I'll talk a little bit about that. And and as I go through the studies, the focus for me today is going to be more about telling you about the way we developed it, the intervention models and how it's changed over the years, as well as our implementation strategies to support task shifting. And then we'll do, I'll go over some of the research results as well. But I think, for many of us who are in the field working, in the field, the things that I find most useful when I'm going to some of these talks is just understanding the nuts and bolts of what it is that we're implementing and how we went about implementing, and then some of the barriers to doing that and the lessons learned from that. So that'll be the focus for today. Are we able to share yet? No?
Okay, here's, it doesn't seem like it. We could do a workaround, which will at least get the slides up. Which, if you send me the presentation,
Okay.
I can share it, since we know I can share. Alternatively, there's another idea that if you leave the meeting and return, it might just kind of reset your sharing privilege.
Okay, so I'll do that. Or maybe do you think it's the link that I used?
No, Mike didn't think it was the link. It just seems like a a problem really without an explanation at this point.
Okay. Okay, so I'll do that. I'll log out.
Maybe send your slides first and then log out so that
Okay.
is a redundancy.
Yeah.
And I've just emailed you, so it's easier to just reply to my email.
Okay. Hmm.
Kind of like the equivalent of the lights going out in the lecture hall, or like a fire alarm. Or
Okay, got it. Here we go. Let me see.
The very old-fashioned version was a slide getting caught in this carousel, but that dates me.
Right, the bulb going out from the projector, Ian says.
Where are we? Okay, it's sent.
Maybe what we can also do, if people already know questions that they think they're going to want to ask, you can start sending those through the chat.
Okay, so I'm going to leave and then I'll sign back on.
Okay, we'll see you in a few.
Okay.
Joe, we might want to warn people that Vicky's indicated that she needs to get off right at 1 o'clock, just so they're kind of forewarned as well.
Oh, thank you. Yes.
Okay, so let me see if I can share it now.
Oh, great.
Does it work now?
Yes.
Okay, great. Okay, so I think, you know, you know, everyone sort of already knows this. This is basically the problem that I focus on in Vietnam is around depression. And the reason for that is because of the, you know, the fact that it's such a big burden on, big health burden, and 1 in 5 people in the world suffer from depression. The focus for me in the last few studies have been focused on women because women have higher risk. They have 2 to 3 times the risk of men. 75% to 85%. And I would say, you know, the world don't receive services for depression, but in Vietnam, probably even higher than that. Depression and poverty are linked. They interact in a negative cycle. And so in order to address depression, especially when you're working in low middle income countries, you also have to address poverty as well. And so the focus of today's work, today's talk will be on an intervention that I developed that integrates depression care with poverty reduction strategies. And just to give you a little context in Vietnam, you know, I know that there's some of you already work in Vietnam, so probably already know, but it's, you know, it's a country that is in transition. It's low middle income, but it's also transitioning to, you know, there's a lot of disparity, especially in the urban areas, because there is a lot of wealth that is growing in the urban areas. There's also a lot of migration that's happening from rural to urban areas. And so changes, lots of changes in demographics. And with that, a lot of stress in terms of adjusting to a transitional society. Family structures are changing, expectations are changing in terms of livelihood and what people can do. And so, you know, that's part of the context that we work with when we're thinking about interventions. Vietnam, like many other places, including in the United States, have inadequate mental health supports. Currently, actually in the last 20 years, I haven't seen that much change. Most of the mental health services are provided out of psychiatric hospitals, and the psychiatric hospital services are still pretty outdated in that it's very focused on severe mental illness and very medication oriented. Even in the psychiatric hospital, there's very little therapy that's provided. There's also very little therapy, especially evidence-based therapy provided in other places like social work centers. A lot of it is really around case management. If psychological services or support services are provided, it's more case management than actual therapy. And there's very limited training for mental health providers, and even amongst health providers, there's very limited awareness and knowledge about mental health problems. And I don't know if you all know, but in Vietnam, a lot of the providers that are a lot of the directors and providers that are in the psychiatric hospital are folks that did not actually choose to be in the field. They were people who are actually basically assigned to be a mental health provider. So like a couple of the psychiatrists that I work with, they're probably in their 50s and 60s, and they actually did not choose to be psychiatrists. They were assigned because of the need in the province that they're in. And so there's a lot of resistance that you have to deal with when you're working in the health system, because it's just not a desirable field to be in. And so, a lot of the work that I focus on is about developing and testing effectiveness of the depression care task shifting interventions, but also adapting it to address the social determinants, and in this case, poverty, and also developing and testing strategies for supporting task shifting. So this is sort of the timeline of the work that I've done. Started in 2007, and there we started talking about developing the program and building capacity in a primary care setting. And that's, when we started basically training the psychiatric hospitals to provide collaborative care model for depression, and also training them in behavioral techniques. And so we started that in 2007, 2009. We implemented and conducted a randomized control study that used a collaborative care model for depression that offered both therapy and medication management. And so therefore it was called the multi-component collaborative care model. And I'll talk more about that in the next set of slides. And then after that, we then adapted that for poverty and expanded the program. And that's how LifeDM was developed. And after the first effectiveness study, then we developed a model for scaling that up and finished that last year. And currently I'm funded for an R01 to test the implementation strategies. So study one is the multi-component collaborative care study. And that, in 2007, we worked in 2 provinces in Da Nang and in Can Hoa province. And there, there's 1 psychiatric hospital in each province. In Da Nang, there was only 37 psychiatrists for 800,000 people. In Can Hoa, there was 7 psychiatrists for 1.2 million. And there was, previous to our work, there was a needs assessment done, and they found 20 to 30% of adults in those provinces to be estimated to have common mental health problems. So, the need was quite large. And at the time that we developed it, we really wanted to develop a model that would fit into the system, the healthcare system. And in Vietnam, it's very hierarchical. There's 8 province level psychiatric hospital in each province. And then underneath the province is districts. And then underneath the district are the commune health stations. And that's basically the first point of contact into the health system, and services there are free. And usually, for the vast majority of folks, especially outside of the urban areas, outside of the large urban centers like Hanoi and Saigon, most people get their care through the community health station. And there, much of the services are very, very basic. It's immunizations, very, very basic support. And there's maybe 4 or 5 nurses. There's 1 primary care, usually a physician or a physician's assistant. And so people get seen there, and if the CHS isn't able to support them, they go to the district, who then usually refers them to the hospital. But because the commune has the reach into the community, we decided to focus our program in the commune health station and utilize this hierarchical supervision monitoring system that is built into the system to support the program. So our collaborative care model involves what we call a mobile psychiatrist. They come from the psychiatric hospital. They then support the community health station staff, usually a nurse, who then also works with a community health worker that supports the community health station to support the patient. And so it's really an integration of the community health station and psychiatric hospital, or a collaboration between those two sites. We used a step care model. And so at the very bottom are the health collaborators, who are they're usually like lay providers, volunteers, and they do a lot of the health promotion, the screening, the psychoeducation, and referral. They refer folks over to the CHS, and in the CHS, we train them to provide basically behavior activation and then guideline medication that is already available in Vietnam. And if people don't respond to treatment at that level, then they get referred up to the psychiatric hospital. We also refer up for more severe mental illness, and for anybody who has had a history of depression that's that's been that hasn't been responsive to medication. So those folks also get referred up. Most of the folks that we have treated at the CHS are mild to moderate depression. So our MCCD component includes community mental health promotion, screening and assessment, psychoeducation, and then in the depression management, it's individual therapy, and then 6 months of medication management. In Vietnam, it's mostly amitriptyline and fluoxetine, but mostly amitriptyline that's available, and then any follow-up support. When we first started, we actually didn't have this community mental health promotion piece. We only had the screening and assessment. And we found that it was really hard to identify people at the community health station because they were pretty, they're not coming in for mental health services. And so their awareness about it and their literacy is very low. And so the detection rates were also really low. Once we started doing more community mental health promotion, those numbers went up, and there was also more engagement into the program. So, in the evaluation work that we did there, we did randomized control study of 475 patients randomized to this MCDC model as compared to just guideline medication. And we actually found that MCCD had higher rates of engagement, faster response, and higher, there was a bigger difference in outcomes for both depression and functioning at 6, 12, and 24 weeks. And so, and also lower dropout rates as well. And so based on that, we decided, to continue with the program. But one of the things that we also found is that in the beginning, those who dropped out of the program, when we interviewed them, most often they dropped out because they didn't understand the relevance of depression care. They didn't see why that was needed. Their, stress was focused on their livelihood and on economic issues, and being happy to them was not something. And that's how it was framed initially. It was framed around mood management, and so it just did not seem very relevant for folks. And so, because of that, we decided to focus on integrating livelihood into our depression care model. And in the MCCD project, there was about, the sample was 75% were considered low income or poor, and also 75% were also women. And so that's why we decided to focus on women. And at the time that we started this work, we also learned that in the women's union that provides a lot of the poverty reduction programs in the country, their success rates for microfinance loans were really, really high, and they focused mostly on women. The women's union focuses actually all on women. There are other programs that provide microfinance support to men as well, but it's really successful for women, and they're provided in groups. And so we wanted to integrate into that. And so that's kind of how the Life DM program was born. And that was a funded NIH R34 project. And what we did there was we integrated the therapy model that we use in the MCCD program with the livelihood components, which included the loans It also included the addition of sessions that use the behavior activation skills and the problem solving skills to address the livelihood stressors. And then, this study evaluated the outcomes at 6 and 12 months, compared it with usual care, and we looked at depression, income, functioning, and quality of life. This is our conceptual model, and this is basically, the focus for us is really on breaking the cycle of depression and anxiety, depression and poverty, and in terms of outcomes, we wanted to see an increase in treatment engagement because we think that repackaging depression care with poverty support, poverty reduction supports, makes mental health services much more relevant and acceptable. And so we believe that would result in greater engagement. And because we're using the depression skills on the economic stressors, we also think that that's also going to increase healthy activities as well, and life functioning, and self-efficacy, and depression, and reduce depression and anxiety. So the model is basically expanded from the earlier model, and so instead of we also have the nurse here, but we also have the microfinance provider, and that's the women's union. Some changes to the program included expanding the treatment session. So we have 12 sessions instead of 5 sessions, which is what we had in the BA, the earlier MCCD program. And we included in a livelihood assessment as well as your general psychosocial assessment. We did screenings outside of the primary care, in the primary care setting, but also outside of that as well, just to increase the reach. And we incorporated finance literacy into our intervention. So in our groups, there's discussion about how do you budget, how do you save, what are the different programs that are available in the community. In the livelihood assessment, the women's union will go out into their homes and kind of get a sense of what they're able to do, what they do for income generation, and what they want to do, and then we put together a plan for them for how they could reach their livelihood goals. And we support them to develop a plan, but in the very beginning, there's like some recommendations that's made by the women's union for the patients in the group. And in terms of implementation strategies and things that we changed when we started the LifeDM project is we included the women's union, here. And so we actually had also additional workshops that included more of the livelihood. So there was expanded workshop trainings, and then the supervision, we included more adherence and quality ratings. We didn't have that in the MCCD project. MCCD project was mostly just more unstructured supervision, where there was a check-in basically weekly by the supervisors, and then monthly after 3 months. In our LifeDM, there was more supervision, and the supervision was structured and involved ratings and feedback on skills. And they provided supervision for the first group consistently, and then the second group was more on an as-needed basis. This is gives you a sense of what it looks like. We incorporated a lot of activities into our groups. And so here you can see, this is sort of like a demonstration of BA for them, playing and doing things outside. So there's a lot of activities. This is a woman who's like selling. Most of the women in our program have these stalls that in front of their homes. So it's very small business. And the loans, we give them a loan of $150, which is not very much even for Vietnam. And they usually use it to purchase things that they need to support their business. And the idea of the loan is not really because it's, it's not really for the purpose of having enough capital to develop a business, but it's really for the purpose of practicing how to use credit and how to create a livelihood plan and reach your goals. And so the amount is small. The other reason why the amount is small is because when we did qualitative work before the project, we found that a lot of the women in our earlier project were very anxious about taking on loans, and they don't, really interact with the financial systems because they don't want to owe any money, and they get, it may exacerbate their anxiety. And so we kept the amount much smaller than most microfinance programs. In our groups, there's a lot of singing and dancing, and it's a very active group. So it's though it's a depression group, it's actually, it's really more of a life group to us. And there's a lot of pride in the groups. Our facilitators decided to have a uniform so that they, so they can identify with the project, and that I think it raises the spirit of the group. And there's a lot of support for group, group livelihood plans as well. And so some groups decide, for example, in this group, that they wanted to sell brooms, and so they'll use their money and pool it and purchase the materials that they need to do things like this. And during the group, part of the group is like, taking care of the tasks they need to develop the income generation, but the other part of the group is actually going through the group content. So, so we conducted for the LifeDM study, we conducted a matched pair clustered control trial, and we compared LifeDM to mutual care. It was implemented in 4 community health stations in Da Nang. We matched the sites, and there were 8 providers, 8 community health nurses, and 8 women's union community providers, sample of 166. The average income in our group was about $100. So, not very high, $100, $95 a monthly income, about. And here you can see the results for depression in terms of the PHQ. So on average, most of the patients that start with this, and this was consistent with our MCCD project as well, were in the moderate range of depression, scores between 14 and 15. In our LifeDM group, which is the red line, you can see that by 6 months, the score went down to about 3. And for the usual care, it is about 11. Then at 12 months, the score, also drops for the usual care. And so that is, the score there was about 7. And then in the LifeDM group, it basically maintains itself. It's around a 3 at 12 months. In terms of income, we also saw some improvement as well. So for LifeDM group, the average income that people started out with, there was more of a difference, because what we found was there was somewhat of a bias in terms of those in the LifeDM, the sites that were LifeDM sites had very high participation and people were seeking it out. So we did some propensity weights to kind of balance that out. But you can see here that the average income was about 90, and then at 6 months it was about 130, and that maintained itself at 12 months. For the usual care condition, the income only increased about $10 or so, and then that sort of maintained itself. And then this is the dotted line is the propensity weights that we used. So, so there was an increase in treatment acceptance, reduction in depression, improvements in terms of economic outcomes, in terms of income, loan participation. There was also improvement in business difficulties. People reported less business difficulty and more we had items on like how effective they felt doing and managing their business, and that was also improved. Functioning was improved. It was basically across the board. We saw pretty high levels of improvement, and these effects were strongest at 6 months, but then they maintained themselves at 12 months. Here is another example of, this is one of the participants who sort of has become our spokesperson. She is somebody who actually started, as part of her behavior activation exercise, she decided to watch YouTube videos and dance, and then she ended up over time kind of forming a dance group for her, for her for her homework assignments. And that dance group has actually evolved and become its own separate group. And the group, because of the work, the things that she's learning in the Life DM program, has evolved into one where they're doing a lot of other group activities. So they will do things like volunteer at the hospital together. They celebrate birthdays. They perform at the women's, there's an annual Women's Day parade and events in the city. And so they've done flash mob dancing, I guess is what it's called. They just kind of show up and dance in a group and invite, members of the community to perform with them. And so this is them practicing on the street. This is them dancing outside or at a performance. So our third study is one where we developed a scale-up model for the Life DM project. It was funded by the GCC transition to scale model. And here the model for us is really focused on a tiered approach where we started out with training at the provincial level and the leadership that is needed in the various systems at the higher level. So we started out with the psychiatric hospital and the districts and all the other support organizations like the Women's Union, the Social Center for Social Work. And they're not all trained to be implementers, but they're all trained in the model so that they understand how they can refer to each other and how they can link up with each other. And then after that is set up, then we move forward to training the commune health stations, because the other projects we did prior to that, without like that larger system, the services weren't sustained. And so we felt we needed to really sustain it outside of the commune health stations. And the other thing we added in the scale-up model is a learning collaborative. And so at the province level, all stakeholders that are involved in the program convene like 3-4 times in the course of like the implementation period of this project. And they focus on solving the implementation barriers as well as going through the PDSA in a very simplified way. And the other thing that happened in this project is the training transition to the local trainers. So I was no longer providing the workshops or providing supervision in this project. Adaptations that we made at this level included really strengthening the community mental health promotion and making that a much more systematic effort. In the MCCD project, we engaged in community health promotion by doing things like providing announcements over the radio and at various meetings. And there was an event that was done in the community, but that wasn't enough. It wasn't sustained. It was just like one-time events for the various health promotion activities. In this project, we actually hired village health workers to go around and promote it for about a period of 2 months prior to starting the project. So that, and then also continuously during the times that we were able to enroll new patients into the groups. So there would always be more engagement and more efforts to have conversations around depression outside of the primary care setting. The other thing we changed in the intervention is we changed the loan amounts to see if having a more flexible amount would be more feasible. And we tried to use the resources that were provided at the Women's Union, both in terms of the loan program as well as some of their other poverty reduction programs. In terms of changes we made to the settings, we added the district clinics so that the district clinics in Vietnam actually supervise the community health stations. The psychiatric hospital doesn't really do that directly. Normally it was only through the project that happened. So we wanted to use the monitoring system within the health system. So we incorporated the district level. And then these other, systems, these other centers, in the end, I'll talk a little bit about how that actually didn't work out as well for us. It was actually much easier to do when it was focused than when we started spreading out. Because the trainings were now all provided by the local trainers, we actually increased the number of trainings. So there was quite a few trainings. There were 5 trainings that were provided, and they were usually 1 to 2 days, well, 1 to 3 days, but the bulk of them were 2 to 3 days. And supervision was the same, and the learning collaborative was different. So the goals for this project was really to increase reach and increase adoption of depression care at the community health station. And we looked at impact on provider outcomes and patient outcomes. But because we weren't, the funding for this wasn't really to do a randomized control study. We basically just developed it and then implemented and looked at pre and post across the phases. We had 34 provincial providers, 42 commune and district providers, and 83 patients at phase 2. And then in phase 3, we actually increased the number of providers to 49. So additional providers got recruited in, and 91 patients were seen in that phase in the research evaluation. Most of the outcomes for the providers improved. So you could see at baseline and then 12-month follow-up, there was improvement in terms of providers' ability to identify clients, screening, educating, prescribing, individual therapy. There wasn't much of a difference in terms of referral, and there wasn't as much of a difference in community outreach and supporting the livelihood process, but there was change in provider outcomes in terms of what was reported by the providers. And we also looked at process indicators. So we had the clinics basically log all their different activities. And so we had screening logs and then also implementation logs. And from that, we extracted these process indicators. So in general, screening rates were pretty high, 629 and 842. So phase 2 is when we provided the supervision. This is like the first group in some ways. Phase 3 is when when we added in the learning collaborative. So it's and this is also their second time of running the groups. In terms of being able to detect depression, it was pretty good. The rates were about 25%, 28% first round, 25% second. Everyone who was identified to be depressed and were offered treatment is the next step here, and it was 81% phase 2, and in phase 3 there was 100%. So the rate of reaching the people they're supposed to reach was higher in phase 3, and we had higher acceptance rate in phase 2 than in phase 3. Phase 3 we had 50%, phase 2 with 70%. Amongst the people who accepted, 75% participated in phase 2, and in phase 3 it was 92%. Rate of completion of the groups was actually really high. That's 85% in both phases, and 77, 76% improved. And improvement in here is defined by, as 50% reduction in their PHQ scores. Recovery is defined as scores of less than 5. And so about 50% basically recovered. And so all of these numbers are actually quite good. This is our rating in terms of adherence to the program. And you could see that in phase 2, which is the first time they run the group, there's much more variability. And then in phase 3, there's all the sites start to look more similar to each other. In terms of the quality, the adherence and the quality, the ratings were actually really good. These are all rated by their supervisor. So every session is rated, and a score of 2 or above, it ranges from 0 to 3. And a score of 2 and above is considered competent for us. And so in both phases, we were able to achieve that with the local supervisors. And we also see here that the dropout rates are really low, and the number of sessions, the average number of sessions that patients got were actually really high. The group is 12 sessions, and average is about 10 sessions. So that's really good for participation. In terms of change from baseline to 6 months, we also saw change improvements across the board on almost all the variables. And so this is very consistent with the earlier LifeDM project as well. The other thing I wanted to add is in this project, we actually also looked at family functioning, and we also saw improvements there. So in terms of the effectiveness of the GCC project or model, that also was found to be pretty good. We improved mental health outcomes and general functioning of participants. We were able to show that livelihood economic outcomes improved in terms of income generation and business management and work productivity. There was also improvement in family functioning. We also assessed their partners, and their partners' mental health also improved and their functioning improved. They also were asked to, both partner and the patient was asked to identify a problematic child and do a rating of their problematic child pre and post, and that also found some improvements. So just in general, the shifting to local providers, local supervision, and local training was successful, and we were able to create a model over time where people did maintain the outcomes that we were able to achieve when we provided the training more directly. At the system level, we also saw that there was an increase in reach and adoption into the community and using the strategies. The quality of care of the depression care was very good, and from the provider surveys, we found improvement in knowledge, attitudes, and practices. Some of the challenges we had, I think, were really focused on some of the challenges that we had were the things that led and inspired the modifications that we've made over time. And so this is sort of a list of some of the challenges we had over time. And so this issue around, treatment engagement and patient engagement were, it was part of the main challenge we had when we were doing the MCCD project. And so when we shifted over to the LifeDM projects over time, the engagement with community was higher. So we'll do some strategies we used included things like inviting former participants who were successful in treatment and inviting them to become community health workers for our later projects. That seemed to be a really good strategy because people were able to, to share their real experience about treatment, and it helped reduce concern around getting mental health services. There was also a lot more games and physical activities that we incorporated. We found that having the group was actually much better than doing the individual therapy, because the group really lended itself to playing games and doing things together, which then also made the treatment more fun. In the earlier MCCD project, some of the feedback we got was that it felt very tiring to be in therapy because they're going through a manual and they're doing homework, and it just felt like homework. It felt like work to them. Whereas in the LifeDM project, the LifeDM program, there was a lot more activity and just seemed more seamless. Like the intervention didn't feel like a working group. And in terms of some of the other strategies we used, I think so. In terms of challenges with implementation, we had a lot of difficulty getting people to follow the step care process, deciding on when they refer up to psychiatric hospital didn't happen as as consistently as we'd liked. And I think part of the issue, like any time there's multiple decision points, it was really challenging. And so in our later phases, what we did is create more checkpoints and more tools to help people make decisions. That seemed to be helpful. And then to train the supervisors to be mindful of the challenge, the pain points in the program, rather than just providing them with general training on supervision, really honing in on the pain points and having them focus on very specific pain points, in the training process. We also simplified documentation and streamlined it, which made it much less burdensome, and much more of a focus on system coordination in the LifeDM project, and then also in the GCC project, getting all the systems to work together. It was still quite challenging in the GCC project to expand and include other sites in the beginning, they all wanted to actually implement LifeDM, and we welcomed it and we invited everybody that was interested in getting the training. But in the end, the systems outside of the healthcare system really had a difficult time maintaining the groups and maintaining the program. The Women's Union was able to do that because they're so linked with the health system, and they really are providing the groups in the health clinic. The sites that tried to provide the groups at the Women's Union centers really didn't maintain themselves after the project. Here's basically a summary of the evolution of the work. We started out with just the MCCD project and then expanding out to Livelihood, and then trying to tease out the implementation strategy. So ES stands for the enhanced supervision model that we use, and then the community engaged learning collaborative is the other implementation strategy. And currently what we're going to test is the comparison between usual implementation, which is basically workshop and technical assistance in the toolkit, compared to ES, which is our structured supervision approach, where the sessions are observed and rated, and there's about 6 months of ongoing coaching that happens. And then the third condition is basically the learning collaborative that we tried out in the GCC project, in that we will incorporate more quality improvement strategies, giving them a dashboard, working on specific pain points, basically identifying the problems, and then having more group problem solving around implementation challenges. And that is done across sites within the province. And so that's our current project now. But basically the lessons I've learned over time is that task shifting works, and system integration can improve access and quality of care. That was actually quite challenging to try to convince the system in the very beginning. We thought that it would work to task shift to community health stations, but we were met with a lot of resistance, especially from the Ministry of Health and any of the higher level folks. And so they really didn't think that providers outside of the psychiatric hospital could provide the collaborative care model and the therapy. And so, across all of the different studies we've done, we've been able to demonstrate high levels of success across a variety of varied outcomes. And I think the other thing is just like an early focus on implementation and implementation barriers and developing strategies for that. Community engagement was really key to getting the participation of the patients, but also the systems, and then the support of the community. Leveraging services and resources that already exist in the system is also very useful, and using a team-based model was also very effective for us. Supervision is really key, I think, in all of the projects that we've done. When people don't go through that lengthy supervision process, they actually don't really achieve the results that we expect, and then that actually decreases their motivation to continue. Having this dual approach of addressing both depression and poverty was really critical for women. We actually had a wait list whenever we opened up a group, because people were so interested in getting the loans, and it really just made the lessons that we wanted to teach around behavior activation and problem solving really relevant and interesting for folks. And so, we didn't have to convince them, and they were very willing to do the homework assignments and participate. So that was really good. And I guess that's it that I have. I don't know what time it is actually.
Well, it's 12:54, almost 12:55. Maybe time for a comment and one question. Thank you very much. Really remarkable. What a blend of a clinical intervention and a point that addresses a social determinant of health. What a nice example, and very important. Thank you.
Yeah.
And one question came in from several questions came in. One to address now from Ian Bennett about which I think was one of the barriers you spoke of at the end, Dr. No, about working with doing screening for common mental disorders with lay health workers. Is there maybe, it sounds like Ian Bennett's running into some barriers with that. Is there more that you might say about that?
Yeah, I think when we first started, we did not frame this. We just did the screening, and we had about 2% rate at the primary care clinics. And so what we found is that people, when you use, especially when you use only the 2 items, the 2 PHQ items, because people are going to say no to both of those items if they don't know you and they don't know why they're being asked these questions. And so when we introduce the why we're doing, we talk about the importance of emotional health and how that's central to physical health. So really framing it around the physical health, because they're coming to the community health station, and so you got to relate it to why they're coming in. And then when we talk about us being able to provide services to support their emotional health, then they're more willing to say, okay, now I understand why you're asking me. So we didn't do that initially, and reframing that really helped. The second thing is we actually use a 2-step screening process. So with the community health workers that go out into the community, they can ask more general questions about depression. So instead of asking like the rating, they'll just ask, have you had poor mood in the last 2 weeks? Yes or no? Have you had difficulty just doing the things that you need to do in the last 2 weeks? Yes or no? And then they get referred to the community health station. And then at the community health station, they get the full PHQ. When we tried to do the 2-item in the community, we just didn't get anywhere. We got very, very low rates. And in the community, it's very hard for them to pull out a rating, and to talk about 0, 1, 2, 3. That's just it's hard for people to process. And so just minor changes like that made a big difference. And also when we talk about behavior activation, we also had to reframe it around functioning to engage people into the treatment, including the providers. The providers were actually not convinced that the therapy model worked, because they're like, why are we telling them to be happy and to take, it just feels very selfish. And so they were not, they felt uncomfortable, and that got expressed to the patients. So the patients are like, I don't know, why we're doing this. And the providers like, I don't know why we're doing this either, but once we framed it around functioning, that made it much more relevant. And once the providers were convinced it was something that was effective, they were better at delivering it.
And it led to 100% acceptance of treatment.
Yeah, which was kind of crazy. Remarkable. We were not expecting that.
Well,
Vicki, this is Richard. I had a question. First of all, congratulations on a decade's worth of incredibly wonderful, exciting work. Do you have a sense that your energy there is beginning to penetrate at the higher levels of leadership in the ministry and the provinces yet?
Yeah, we're actually in conversation with the Hanoi University of Public Health, and we're going to try to integrate our training into their curriculum so that we can train public health providers that will come out of the school, who will then go out into the community health station and the districts and the departments of health around the country. And so we're in conversation to try to create like a different model of scaling up.
Wonderful.
Yeah.
Well, thank you again. I'm aware of the time and the upcoming commitments for many of us here. Thank you for presenting. And I think it's an opportunity to potentially create ways to continue to be in touch and to learn more about your work. So thank you for presenting.
Thank you for having me. I wish I had more time for a discussion, and thank you so much.
Thank you, Vicki.
Bye.
Bye.
Goodbye.